My name is Katie Brooks. I am an LCSW EMDR certified therapist and approved consultant. And I'm also the clinical director and founder of Good Therapy San Diego, which is a group private practice with 3 locations in San Diego County. We have a location in Oceanside, Carlsbad, Encinitas, and Sorrento Valley. So in my last videos, I did tutorials on how to apply Flashforward technique and mental video check to help with future feared scenarios. This tutorial is going to be about applying and integrating Flashforward and mental video check into protocols to treat panic, OCD, and phobias. So let's get started. We're going to start with the phobia protocol. And the protocol that I like to use is by Francine Shapiro. There are other protocols that are much more succinct and targeted. This one is a more of a comprehensive approach. And it's a little more time consuming, but for the purposes of this video, I want to give you multiple strategies in order to treat this disorder. I know Jongh, who's a specialist in anxiety disorders, has a more targeted treatment and protocol for EMDR, and you might want to check that out. I believe he starts with the worst and then targets any memories that specifically drive the symptoms. But I'm going to start with Francine Shapiro's protocol, and the way that she targets her sequence is she starts with the first event that initiated the phobia. So you'll want to identify the sensitizing incident, right? The worst experience related to the fear is next. Then you'll want to target the most recent triggering event. And then you'll move on to any antecedent or ancillary events. These are events that prime the system, but let's go down here a little bit and figure out what these are. So these are events that occurred before the onset of the phobia, but they don't directly cause them. They do, however, prime the nervous system and shape the core beliefs. So some examples of this might be if like a child grew up with a very anxious parent and then later developed a fear of driving. Another example of this would be repeated exposure to medical trauma and then having their first panic episode at the dentist, right? So you'll want to target that medical trauma because it mimics that feeling of being out of control that he or she had at the dentist office. So those are antecedent or ancillary events, and you can usually get to those using the flow back technique from the standard protocol. Then we're going to move on, or she moves on, to the physical sensations. These are body-based fear responses. I'm sure you guys have felt tightness in the chest or dizziness in response to fear. Well, you could get a feedback loop in where you actually fear those sensations. So you'll want to target those if those sensations have become fearful themselves. Then you move on to the Flashforward technique and the mental video check. Like I said, I explained how to do those in my last video, so you want to check those out if you need a review or haven't seen my last video. And these are to address any future feared scenarios. Then you'll move on to exposure exercises if they're needed. Or they're possible. I'm going to show you a case example where it's not really possible and it actually might do harm to the client if I was to do it. But oftentimes with phobias, you really will want to do some exposure after you've done your EMDR protocol to get that real world application and test to make sure that the client can actually face their fears in real life. So let's move on to a case study where we have a sleep phobia. So the presenting issue is a 25-year-old woman with a phobic response to not sleeping, panic at bedtime, racing thoughts, compulsive sleep rituals, avoidance of sleeping plans, and intense fear of sleep deprivation consequences the next day. The first event that was processed originated during finals week, where she couldn't sleep and failed the test. So the target memory would be, I lay in bed until sunrise thinking if I don't sleep, I'll fail everything. So there would be an image of her laying in bed, having those ruminations, and the negative belief would be, I'm going to fail. And then you move on with your TICEs, with your positive cognition, your emotion, all the good stuff, right? In your TICEs, and you're going to clear that. So once the first event is clear, you're going to move on to the worst experience. And in this case, she had a panic attack in a hotel room before a business presentation and fainted the next day. The target memory was room spinning, heart racing, thought I might die from exhaustion. Once you've cleared that, you move on to the most recent trigger, where she couldn't sleep despite self-care efforts, spiraled, overdosed on melatonin, Google symptoms obsessively, which is quite common with people with health anxiety or anxiety disorders in general. And the target memory is watching the clock, thinking I won't survive tomorrow. Then we moved on to the antecedent event, where she had an anxious, perfectionistic mother and who emphasized performance. Target memory was mom waking her up to double check her alarm for school. The core belief is if I don't control everything, I'll fail. So once you've cleared that antecedent event, you move on to the physical sensations. Now, I only did one antecedent event. Oftentimes during reprocessing, antecedent events or developmental big T or little t trauma will pop up, and I want to take notes of those and clear all of those past memories before moving on to the physical sensations, if there are, for phobia. In this case, she had tight chest, racing heart, stomach knots, obsessive fatigue, scanning, hypervigilance. So you'll want to treat these like individual present triggers and clear each one before moving on. Then we moved on to Flashforward and mental video check. The catastrophic scenario for her was lying awake before a client meeting, having a panic attack at the meeting. And you'll want to TICEs that like a regular target with that catastrophic event as the image. Once that flash forward is cleared, then you apply the mental video check, where you'll want, and especially in this case, she had to imagine navigating the next day while sleep deprived but composed, right? So you're going to drop the catastrophic event and have her imagine coping adaptively with her feared scenario. Once that is successfully completed, or once that was successfully completed, because this is a case study, the outcome was significant reduction in bedtime anxiety, reclaimed evenings, and the belief shift was, even if I don't sleep well, I can take care of myself. So good for Anna. Let's move on to panic disorder. So Francine Shapiro's EMDR protocol for panic disorder is also comprehensive, and I like it very much. So we're going to go ahead and use hers. The target sequence in order is close to, excuse me. All right. The target sequence in order is the first panic attack. You want to target that first panic attack, the worst panic attack, and then the most recent panic attack. So it's going to be very similar to the phobia protocol. And then you'll want to go into additional reinforcing events, any other significant experience that intensified the fear, the physical sensations. Fear of physical sensations is actually the most common with panic disorder. And you really don't want to skip this step, because usually they're the reinforcing symptoms of panic disorder. So people, once they have a panic attack, they believe that they're dying, they have a traumatic experience. The panic is a traumatic experience in and of itself. They become scared of having a panic attack. And then the individual symptoms that come with the bodily sensations that come with the panic. And so folks will start to avoid anything associated with that panic, which then reinforces the fear, and it will increase the frequency and the likelihood of having more panic attacks, right? So it's the fear of the panic itself. So you definitely want to reprocess the physical sensations for panic disorder. Then you move on to the flash forward technique. Again, this is targeting the catastrophic what if scenarios. Move on to the mental video check to test for distress reduction and adaptive integration. And then move to exposure episode or exercises. When you use EMDR to desensitize the fear, exposure becomes much easier for the client, way more accessible, right? So oftentimes exposure therapy is really difficult for clients to engage in because, of course, you know, intuitively we avoid feared objects and things, right? And so asking somebody to challenge their fears and move right into it right away without desensitizing and reprocessing the cognitive beliefs is really difficult for them and can be terrifying. So I love using EMDR prior to doing exposure exercises because, like I said, it desensitizes the fear. So it's easier to move into that challenge. And it also reframes the cognitive belief and it clears the body sensations that are associated with the panic. Okay, so let's move on to a case example with panic disorder. We've got Mike's panic disorder. The presenting issue is a 30-year-old male presenting with panic disorder and avoidance of exercise, driving along the highway and plains. He also fears when his heart rate increases, feeling dizzy, and when his chest is tight. Excuse me, it was driving alone on the highway. So the key targets that you want to get to with this case example is the first one. His first episode was panic attack while playing basketball. The worst was a severe panic attempt to board a plane. And then the most recent was driving alone on the highway, having panic symptoms. And so you'll want to clear all those targets, and then you'll get to the physical sensations target. And he specifically was afraid of dizziness, increased heart rate, and chest tightness. And so you'll want to clear each one of those as if they're present triggers. And then his flash forward targets were having a heart attack while driving on the highway with no one around to help, and collapsing on the basketball court from a heart attack. And so each one of those is dealt with separately and cleared separately. Then you move on to mental video check. Actually, what I would do is clear having a heart attack while driving on the highway with no one around, and then you move on to that mental video check. Flash forward and mental video check have a symbiotic relationship, so you'll want to do those at the same time with each target. So the next one would be collapsing on the basketball court from having a heart attack. You clear that, and then you have him visualize a whole game of basketball without distress as the mental video check. Hopefully that makes sense to you. Then you will move on to exposure tasks. In-session exposures would be watch a video of someone driving on the highway alone. You would want him to do some interoceptive exposure. Interoceptive exposures are internal sensations and signals coming from the inside. So in order to do that, we would have him perform jumping jacks in the office to safely elevate the heart rate while the therapist is there. Homework assignments at home. The driving exposure would be to gradually practice driving on the highway alone. Phase 1 would be 20 minutes, phase 2, 60. Phase 3 is a 3-hour road trip to loved ones. I always like a positively reinforcing event after having to do a challenge like that. So I had him drive to family members. And then the exposure exercise, or the exercise exposure, was to play basketball first for 20 minutes, then for 40 minutes, and then play a full game. The outcome of this is that the panic attacks subside and he is able to effectively play basketball and drive on his own. Okay, so let's move on to OCD. The protocol for OCD that I use is the Marsden Protocol. So I want to preface that CBT with ERP remains the gold standard for EMDR. And the gold standard for treatment with medication for OCD. But EMDR offers a promising alternative approach. I actually just took a training with Jongh, who said that there's some recent studies coming out that says that there's no significant difference between outcomes between EMDR and CBT in treating OCD. So that's really exciting. And that also mimics the experience that I've had treating OCD. Like I said before, using EMDR to desensitize and reprocess the OCD structure first before doing exposure is so much more effective in my eyes, because the client is less scared of doing the exposure exercises up front. So that's my experience of it. So the Marsden Protocol sequence is you're going to target all the current obsessions, address any intrusive thoughts, images, or urges that trigger significant distress. Then you're moving on to target the compulsions, process the urge to ritualize or act to neutralize the obsession. Then you'll move on to the Flashforward technique. So this is, again, desensitize, imagine catastrophic outcomes if the compulsion is not performed, right? So if the compulsion is to wash your hands because you have a fear of germs, you're going to ask your client, what's the worst thing that can happen if you don't wash your hands? And that is going to be your flash forward target. Then you will move on to the mental video check to test whether the distressing scenario has been effectively resolved. So in that case that I was just talking about, you would have your client narrate out loud a story from beginning to end of touching the door handle and not washing hands. And if distress comes up, you'll use bilateral stimulation. But once they can narrate the story from beginning to end without distress is when you know that it's been effectively resolved. And then after that, you will do optional behavioral exposure, particularly if avoidance behavior still persists. It's not a core component of Marsden's protocol, but I like to use it, especially after EMDR processing. It's helpful to test where the client is using real-world in vivo exposures. Then after that, only after that, after processing obsessions and compulsions, then you explore the past if needed. So if symptoms still persist or past traumas emerge during processing that you've gathered, you'll want to process the early experiences, attachment themes, or core beliefs. Usually folks with anxiety disorder suffer from excessive responsibility, fear of harm, and need to control. And those will be your themes around your negative cognitions that you would use your float back for. So let's move on to the last case study. Her name is Anna. She's got health anxiety or OCD with OCD symptoms. The presenting issue is a 32-year-old female with persistent intrusive thoughts about having terminal illness despite medical reassurance. Engages in compulsive body scanning, internet research, and repeated doctor's visits. I am only going to give you an example of one obsession and one compulsion. Usually with these folks, they're going to have multiple obsessions and compulsions, and you'll want to make sure that you clear each one of them before you move on. But like I said, just for the purposes of the length of this video, I'm only going to go over one. So her obsession was, her first target and obsession was, I might have cancer, which was a recurrent intrusive thought after noticing a mole on her leg. The negative cognition is, or was, I'm not safe, something is wrong with my body. The positive cognition was, I'm healthy and okay. The emotion was fear. The SED9 body sensation was tightness in chest. And so the outcome of this one was the target was cleared after several sessions. During processing, the client connected the fear to a childhood memory of her mom being hospitalized suddenly. So when developmental trauma, big T or little t, shows up during processing, you'll want to hold on to that and make that a part of the active treatment plan. So I'm going to hold on to that past event, and then I'm going to move on to compulsions first. So the next target was a compulsion of Googling symptoms multiple times a day. It's an urge to act, a belief that researching will protect her or help her catch something early. The negative cognition is, if I don't check, I'll miss something and die. Positive cognition is, I can handle uncertainty. The emotion is anxiety, SED is 8, and the body sensation is tension in the chest and shoulders. Now, you can get her, for the first part of targeting this with your TICs, you can either use an image, or you can actually target the thought itself as if it's an obsession. So either way, you'll be able to get it. But if you can capture an image of her Googling her, then that's great. But otherwise, you can just target the actual thought itself. Hopefully that makes sense to you. And now I've also provided some positive cognition options for this one in particular. Now, what my consultees and my associates have said in the past to me, especially in the beginning of learning EMDR, is that they have trouble with positive and negative cognitions. And what I've told them is that you'll want to have, as you're coming up with this collaboratively with your client, you'll want to have a handful of options for them if they get blocked, right? Sometimes your clients, when you ask them, what is the negative belief associated with that, they might say, I don't know. And so it's really important to have a handful of options for them. And for this one in particular, here are the handful of options for positive cognitions. It's, I can trust my body. I am safe now. I can handle uncertainty. My body can take care of itself. I don't need to be in control to be okay. I have strength and I can face it. And so what I would do is, if she said, I don't know what the positive cognition would be, I would give her these options and then ask her, which one do you want to believe, but you don't believe at all? Right? And then she would choose one of those and we would move on, right? For the negative cognition, usually I say, which one of these negative beliefs packs the most punch for you that you really relate to? Okay, so after the compulsion was cleared, it becomes less urgent. The client stated, it's exhausting and I never feel reassured anyways when I Google. So then you move on to target 3, which is the flash forward. Her flash forward in particular was getting a diagnosis too late and dying in a hospital. The scenario is she imagines being told she has stage 4 cancer and hearing it's too late. That's the image. The negative cognition is I'm powerless. Positive cognition, I can handle whatever comes. Alternatives to that are I have strength or I can face it. Emotion is terror or helplessness. That is 10. Usually flash forwards are 10 because it's, it's their worst fear, right? So don't get scared if that's the case. And then the body sensation is heavy chest, pit in the stomach, tight throat. Once the fast forward is cleared, the client reported, I can accept that I can't control everything, but I trust myself to handle whatever comes. I don't need to live in fear of what might happen. So wonderful. So then you move on to the mental video check after flash forward. The therapist guided the client to imagine noticing a new bodily symptom and choosing not to engage in her usual compulsion of checking Google. The client narrates the day of seeing the new symptom with her eyes closed. But then opened her eyes when she said, I see the spot, I feel anxious, but I remind myself I've been here before. I take a breath and move on with my day. Well, when she reported that the mild spike in anxiety, the therapist is going to apply one set of fast BLS. And then we're going to have the client close her eyes and continue narrating her day until she is able to complete the whole story, the whole narration without further distress. So once she finishes the story, she's going to start at the beginning again of narrating her day with her eyes closed, open her eyes if she feels distressed, do one fast set of BLS, continue narrating to the end. You continue doing that over and over and over again until they can narrate the day without distress, even though they're aware of the symptom. Right? So the lack of distress indicates an increased tolerance and adaptive coping, which is very exciting. So then we're going to move on to that past event. Remember that past event that popped up during the clearing of the obsession is targeted last after all the obsessions and compulsions are cleared. The memory that surfaced for her was watching her mother faint and be rushed to the ER at the age of 9. The negative cognition is people can die suddenly, therefore I am not safe. You are going to go ahead and Tisces that and clear it. If you feel that further reprocessing is needed even after clearing that past event that popped up, you can use a float back to get to those past memories once the OCD structure has been desensitized with EMDR. So mostly the target negative beliefs are going to be, I'm not safe, I can't handle this, and I'm powerless. So you'll use your float packs with those. But remember, this is case specific. So when you're doing your EMDR with your obsessions and your compulsions, please pay attention to their negative cognitions that are showing up. Usually they are repetitious, right? And with this specific little lady, she had definitely, I'm not in control, I'm unsafe, right? If we remember, something's wrong with me, right? So I'd want to do a float back from those negative cognitions. Or a recent experience that she had where the compulsion, she had trouble not engaging in the compulsion, and go ahead and do a float back from that recent experience. So that is EMDR protocols for phobias, panic disorder, and OCD. With a clear step-by-step protocol, EMDR can dismantle the fear structures behind phobias, panic, and OCD by targeting the root events, key triggers, physical sensations, and using the flash-forward technique for future fears. Clients can move beyond symptom relief to reclaim confidence, resilience, and choice. So when we target the roots of fear, we don't just reduce symptoms, we give our clients their lives back. And I don't know if you have been or experienced, been near to somebody who has an acute anxiety disorder or have experienced it yourself, but when the episode is resolved, there is an immense relief and functioning returns back to baseline and even past that. And when that relief is felt, I mean, it is so wonderful for the client. So I highly recommend using these protocols. They are highly effective and your clients will be better for it. Thank you so much. Again, my name is Katie Brooks. I am the clinical director and founder of Good Therapy San Diego. You can reach us at goodtherapysandiego.com and intake at goodtherapysandiego.com. Thank you so much, and I hope you guys are having a wonderful day.